Good morning, everyone. It's 7 o'clock, time for grand rounds. Thanks for being here bright and early this morning. We've got a great presentation scheduled here by our own Dr. Shapiro, who's been with us since 2021, 3 years now. Prior to that, he did his residency in medical school at University of Wisconsin, and then did his urologic oncology fellowship at MD Anderson. He's doing some really interesting research on kidney cancer, looking at the immune microenvironment and trying to develop some immune microenvironment signatures and biomarkers for kidney cancer. But today he's going to talk to us about one of his other passions, which is the non-extirpative management of upper tract urothelial carcinoma. Dan, we're glad to have you as part of our team and looking forward to the talk this morning.
All right. Yeah, thanks a lot, Dr. Richards. So today we're going to focus our discussion on the non-extirpative management of upper tract urothelial carcinoma. So basically managing upper tract disease without radical nephroureterectomy. So the objectives of this talk is I want to have a discussion that'll familiarize the residents and also the faculty and staff on the relatively new 2023 upper tract urothelial carcinoma guidelines. Then we'll also discuss and evaluate the efficacy of different non-extirpative techniques for management of upper tract disease. And then lastly, we'll discuss the role of adjuvant and topical therapies for the management of upper tract urothelial carcinoma. So to set the stage, I present a 77-year-old female who presented with gross hematuria to my clinic. Her past medical history was not particularly remarkable, and she had no personal or family history of urothelial carcinoma. She did have a significant smoking history with a 25-pack year smoking history. So as part of her evaluation, as is recommended, she had labs, a CT urogram, and then also a cystoscopy in clinic. And her labs demonstrated on her UA that she had 25 RBCs per high-powered field. Her GFR was 65, and then her CT urogram shows a right upper tract filling defect that was concerning for possible urothelial carcinoma. And then her clinic cystoscopy was negative. So obviously the next step in management for this patient would be tissue sampling to confirm our suspected diagnosis of upper tract urothelial carcinoma. Now, diagnostic surgery for upper tract disease does have guideline-based recommendations per the new AUA 2023 guidelines. And so obviously during your diagnostic ureteroscopy, a biopsy is recommended, but it's also recommended that you obtain a cytology at the time of surgery. And so this is typically performed by getting a wash directly from the renal pelvis or near the area of concern, because getting a cytology from that area improves the cellular concentration and gives you a better sample for the cytology evaluation. I personally like to sample both the bladder and then also the upper tract with an access catheter independently, just to see if there are any differences. But you should at least get a directed cytology from the area of concern. And it's also important that when you're doing your cytology, obviously to use saline and not water so that the cells aren't lysed, and then also making sure that you do the cytology before you do any sort of retrograde pylography or inject any contrast. And so if you find during surgery, it's funny because Dr. Pallone and I were just talking about this, but if you find during surgery that the ureter is too tight and you're having difficulty passing your scope, you can try gentle dilation techniques, passive dilation, but it's recommended that you avoid doing any significant dilation with like balloons or access sheaths, because what's different about this situation than like with a stone is if you do end up with a ureteral injury or perforation, you can risk seeding the retroperitoneum with urothelial carcinoma. So it's recommended that if you encounter any resistance to just place a stent and then come back soon. And then also the question comes up if you should be doing any sort of look at the contralateral kidney at the time of the ureteroscopy, like do a diagnostic ureteroscopy on the contralateral side. And it's recommended against this, first because it's unlikely you'll find anything if there's no indication, and second, you're putting the patient at undue risk and potentially seeding that contralateral tract with urothelial carcinoma. And so when you perform your ureteroscopy, it's very important that you have thorough reporting in your operative note. This comes in handy for later risk stratification, which we'll talk about in a little bit. And also at places like ours, academic institutions, this information is important for research purposes. And so this is actually the recommended AUA guideline operative note and what should be reported in the note. And you can see it's quite detailed, but later on you'll understand why, because a lot of these things that are recommended to be reported on fall into the risk categorization. So it's important that you document this so that you can later accurately risk stratify. So just some quick facts about upper tract urothelial carcinoma. It accounts for about 5 to 10% of all urothelial carcinomas. So it's a relatively rare phenomenon. It's most likely that you'll find the tumors in the pilocalicele system and less likely in the ureter. It's about 2 times more likely in the renal collecting system. Also, about 5% of upper tract will recur in the contralateral upper tract. So while it's rare, it is obviously important that you're surveying the contralateral side to make sure that these tumors don't recur somewhere else. And then about 1 in 5 patients will actually have concurrent bladder cancer at the time of diagnosis. So if you do have bladder cancer patient, it's also important to evaluate the upper tracts. And then lastly, about 40% of patients with upper tract urothelial carcinoma will ultimately recur in the bladder. So this comes up with patient counseling. My patients often ask, especially after like a nephroureterectomy, well, why do I need my bladder surveyed? You've already taken out the cancer from the upper tract. And this is the reason why a lot of patients will subsequently recur in their bladder. So performing cystoscopic evaluation is incredibly important in this patient population. And so that kind of brings up the question of how is upper tract urothelial carcinoma different than in the lower tract, and are they different at all? And then also for the patients who recur in their bladder after having upper tract disease, are those cells related and do they have the same origin? And so this study attempted to evaluate that. And they looked at how genetically similar the tumors were from patients with upper tract disease and bladder cancer. And so they performed targeted next-generation sequencing of specific gene mutations to evaluate the relatedness of the tumors in the upper and lower tract. And so they had 195 upper tract urothelial carcinoma samples that were obtained after nephroureterectomy, and then 454 bladder cancer samples. And then they also, within this cohort, had 29 patients that had upper tract disease and then subsequently developed bladder cancer, so they could look at the clonal relation between those 2 samples. And so using their targeted gene sequencing analysis, the authors found that in upper tract disease, TP53 mutations, RB1 and ERBB2 were less frequently encountered. And then in upper tract, FGFR3 and HRAS were more frequently encountered compared to bladder cancer samples. So there did appear to be some specific genetic differences in these 2 tumor types. And then they also looked at mismatch repair and upper tract urothelial carcinoma. And the reason they did that is upper tract is known to be associated with Lynch syndrome. And so patients with Lynch syndrome have germline mutations in mismatch repair genes, and that results in tumors that have microsatellite instability. And so the authors evaluated the incidence of mismatch repair deficiency by calculating the tumor mutational burden, and then also looking at the microsatellite instability scores of the upper tract tumors. And they found that upper tract tumors had significantly higher somatic mutations per megabase compared to the bladder tumors, and that 7% of the upper tract tumors actually had microsatellite instability or mismatch repair defects. And so the authors tried, but they couldn't find one single metric that would identify all mismatch repair tumors. So the authors recommended that essentially all patients who have mismatch repair or microsatellite instability in their tumors should get genetic counseling and genetic profiling to identify those patients who have Lynch syndrome. And so based on these studies, the AUA and the EAU recommend that all upper tract urothelial tumor samples should be tested for Lynch-related cancers. And so to do this, they recommend looking at mutations of mismatch repair, and MSI testing should be performed. And so our pathologists we'll do IHC for these mismatch repair proteins, and if they see loss of protein expression or MSI-high tumors, then that'll prompt a genetic counseling consultation and germline testing. And so people have also discussed doing clinical screening using things like the Amsterdam 2 or Bethesda criteria, but unfortunately, these clinical screens often miss a lot of patients with Lynch-related tumors. And so it's really recommended that these tumors undergo specific testing. And just for reference, I have the Lynch-related cancers listed up here. And so the authors of this study also looked at the relationship, as I mentioned, between the tumors among patients who developed lower urinary tract disease after having a nephroureterectomy. And this occurred in about 42% of their upper tract cohort. So as I mentioned, again, high rates of recurrence in the lower tract. And it occurred at a median of 7 months from their upper tract diagnosis. So a lot of people recurred relatively quickly. They found that FGFR3, KMD6A, and CCND1 mutations were more often associated with bladder cancer recurrence. And additionally, among the 29 patients where they had samples from the upper and lower tract, 16 patients underwent evaluation to look at the clonality of these two tumors. And among all 16 of those patients that they tested, they found a shared clonal origin for all of the tumors. So it does indeed appear that these lower tract recurrences may be directly related to the upper tract disease. So what can we learn from this study? I think it's a really interesting study, and it shows there's a relationship between upper tract and lower tract tumors among the patients that have both. And a biopsy of one does not necessarily guarantee similar histology or aggressiveness. So you can't omit biopsy of one for the other. If you have tumors in both areas, you have to biopsy them both. And then this and other studies have also demonstrated opportunities for potential targeted therapies just for upper tract disease. So for example, there's increased level of FGFR3 mutations in upper tract, and that has led to clinical trials evaluating infigratinib, which is a FGFR3 inhibitor. And people are also looking at this in the localized setting. So we're likely to see more of these clinical trials as time goes on. So after you get your biopsy, you do your ablation, you get the pathology back, the most important thing is to appropriately risk stratify the patients. And so this is the AUA recommended risk stratification system. It's obviously quite detailed, as you can see, but the rationale behind these risk groups will become apparent in a little bit as I'll show you some of the studies that led to this. And you can see that there's two main categories, high and low risk groups, which are primarily based on the biopsy grade. Additionally, each high and low risk group are substratified into favorable and unfavorable risk groups. The high risk group in general should be moved towards surgery with systemic therapy either before or after in the neoadjuvant or adjuvant setting. But for today, we'll focus most of our discussion on the low risk group. One important thing I'd like to point out is the biopsy grade and the cytology grade. So you can see that if you have a low-grade biopsy, so tissue biopsy, but if you have a cytology that's high grade, this actually could push you into the high-risk categorization. And so having a high-grade cytology does change your risk stratification. So that's why it's important to get cytology at the time of your surgery. And we know that the biopsy concordance isn't 100% accurate between what we do endoscopically and what will ultimately be present on a nephroureterectomy. And so that's why it's important to figure out if there's any evidence of high-grade disease, both with tissue biopsy and cytology. And so just for comparison, this is the EAU guidelines. So you can see a lot less detailed, but I think very good in terms of your day-to-day clinical approach to these patients with upper tract urothelial carcinoma. So back to our patient, we did our ureteroscopy and biopsy, which showed low-grade TA urothelial carcinoma, and the cytology was negative, and we ablated at least 50% from what I can estimate, but obviously, visibility, as those of you who have done these know, can be difficult. But based on this, how should we progress? Well, this patient, first what we would do is go back and ablate the remaining amount of tumor, but as long as you don't get a subsequent biopsy that shows high-grade disease, this patient would be considered low risk. And so obviously we would want to perform endoscopic management of this tumor to avoid a nephroureterectomy. But why is it obvious to do endoscopy and not just take this person for a nephroureterectomy? Why is renal preservation so important? We want to cure their cancer, and we know that a nephroureterectomy will definitively eradicate the tumor, and their risk of recurrence is lower with nephroureterectomy. So wouldn't it be better just to take the kidney out and not try and preserve the kidney? But I want to just do a thought experiment comparing the mortality after a radical nephroureterectomy. Let's say the patient ends up on dialysis after you do your nephew. The patient's renal function, for example, is not that great. Well, the estimated 5-year survival on dialysis is only 42% based on this New England Journal of Medicine article. So that's quite a lot of people who die just from dialysis. And if we look at the 5-year cancer-specific survival after nephroureterectomy for low-grade upper tract disease, 5-year survival is almost 100%. And even with high-grade disease, the 5-year survival is about 70 to 80%. So while you may have cured their cancer, about half of these patients that you put on dialysis would end up dead. So have you really benefited those patients by curing their cancer? And even in a less extreme example, so going back to our patient, we expect a nephroureterectomy in someone with perfect kidney function to result in about a 30-ish% reduction in their eGFR. And this is based on our patient's normal GFR. So at a baseline of 65, her new renal function would drop to about an eGFR of 44. And so that's associated with about an 80% increase in 5-year mortality hazard rate. So while I may have cured her cancer, I put her at a substantial risk from an all-cause mortality perspective, regardless of the risk of her cancer. And I could have achieved a similar outcome and cancer control while not reducing her eGFR just by performing endoscopic management. So you can see why it's important, based on these kind of studies, why renal preservation is critical. And it's also equally important to understand what are the indications for renal preservation. And we typically classify this into imperative and non-imperative indications. And so for patients with a solitary kidney or substantial renal insufficiency, presence of bilateral tumors, or their inability to tolerate a nephroureterectomy, we typically consider these as imperative indications. Now, you may not always be in a situation where you have an imperative indication and you can preserve the kidney, but in general, you should do everything you can possible to try and preserve the kidney in this situation. And then non-imperative indications would be the presence of low-risk favorable upper tract urothelial, and in the guidelines, this is a strong recommendation. And then the presence of low-risk unfavorable upper tract disease. In the guidelines, this has less of a strong recommendation, is considered more of an option. So these patients, you could consider moving towards nephroureterectomy. And then lastly, the presence of select cases with high-risk disease that maybe have a very small tumor that can be completely ablated, and you can watch closely. You could consider endoscopic management for these, but in general, you're moving these patients more towards a nephroureterectomy. So how do we get these risk stratification categories? This study is probably one of the better studies that have been performed looking at risk stratifying patients for kidney cancer or kidney sparing surgery and upper tract disease. The main concern with kidney sparing is that you're missing higher stage tumors when you perform endoscopic management. And so this retrospective study from European Urology, they looked at 1,200 patients that had undergone a ureteroscopy and then later underwent a nephroureterectomy. And they looked at patients over a 17-year period. And they took the outcomes from these patients and they developed a nomogram to try and predict the patients that were likely to have high-stage tumors at the time of their nephew after an initial attempt at conservative management. And so they found the strongest predictors of having this higher stage disease are fairly obvious. So having invasion on imaging, having clinical T1 or higher disease on biopsy, and then also having a sessile tumor architecture and having high-grade tissue biopsy were all the strongest predictors of having higher stage disease. But they took all the predictors that they found and they developed a nomogram. And you can see from this nomogram, a lot of these predictors are present in the AUA risk stratification system. So this kind of informed how those risk categories were developed. And then the authors took this nomogram and they determined whether or not it outperformed other clinical staging systems and models. And they found that obviously their paper was published, so they found that their model had the best performance, and they congratulated themselves. But I think this is a good study and informs how we risk stratify patients. So moving on to some of the technical aspects of upper tract endoscopic management. So we can manage these patients endoscopically, but I always tell the residents that you really have to shift your frame of reference for what this type of ureteroscopy is. This isn't going to be a 20-minute case. These are often long and tedious operations, and they can be somewhat challenging and oftentimes frustrating, but you just have to shift your thinking about this type of operation, and it's not going to be a small stone where you feel really satisfied at the end. It's also really good that you have an arsenal of different techniques for different types of tumors. For getting biopsies, one option is to use the piranha biopsy forceps, and there's also the bigopsy forceps, but I usually use the piranha or a basket. And so for the piranha, I like to use a technique where you essentially grab the tumor at the base, and this works best for small tumors that are kind of on a stalk, but you grab the tumor at the base, and then rather pulling the biopsy forceps back, actually push it forward, and this works well in the ureter because you can then directly visualize what you're doing and you can see the adequacy of your sample, and then you don't risk pulling it into the scope on accident and then shearing the tumor off from your biopsy forceps. And so the downside with the piranha biopsy forceps, as you all know, is it gets very, very small tissue samples, so it usually requires multiple passes to get an adequate sample for histologic evaluation. And then also the biopsy forceps is somewhat fragile, so if you use it too much or use it too aggressively, it'll just break and then you have to get a new one. And then the other option is to use baskets, which I think are a really good option for getting a lot of tissue out and debulking larger tumors. And they basically lasso the tumor, and then you can extract a pretty high volume, and you can do multiple passes and get, debulk pretty large tumors. The downside is, they don't work well for the sessile tumors that you can't get the basket around. And I personally like to use the end circle basket, but whatever basket you prefer is fine. And then in terms of ablation of the tumor, I think laser tumor ablation is my first line option for ablation. So after you've sufficiently biopsied and debulked, you can use the holmium or the thulium laser and ablate the tumor. The problem with the laser is the hemostasis isn't always amazing. And so sometimes I will switch between the laser and the bug-bee. There's a ureteroscopic bug-bee electrode that is good if you have like one pumping vessel or it's getting really bloody. The downside of the bug-bee is it's a little finicky, and if there's a lot of tumor tissue, it kind of gunks up on the tip of the bug-bee and you have to clean it frequently. But those are both good options. And overall, you have to accept the fact that it can be a little tedious, and it might take 2 or 3 times to the OR if you're really trying to preserve the patient's kidney to adequately debulk a tumor and make sure you got all the residual disease. And then in terms of ureteral access sheaths, there is evidence to suggest that these are useful for upper tract cases. Sheaths have been shown to improve the diagnostic concordance between the biopsy and the nephroureterectomy specimen compared to patients who did not have a sheath. And it's likely because you're able to sample more and you're able to sample deeper by going back and forth multiple times. And it requires less time if you have the sheath in place. Then also there's better flow for visibility issues. And so in between your passes, you can irrigate and really clean up all the bleeding so that you can see better. Obviously, also one of the advantages of the sheath is because these are longer cases, it'll help reduce the intrarenal pressure, which can be a real concern with these cases because you might be in there for a while. Also, there's a theoretical reduction of tumor seeding the lower tract with a sheath in place. This is based on some retrospective series, but I think that's a little questionable because a lot of times after you use the sheath, you put a stent in, and so that kind of negates the effect of avoiding any tumor seeding from the upper tract, but there is some evidence to suggest that. So I use sheaths for every proximal ureter and renal pelvis case, and I think it's really important for getting good amount of tissue and visibility and reducing renal pressure. So this is a list of outcomes for patients with retrograde management of their upper tract urothelial carcinoma, and it's based on multiple series of patients. And in general, the rate of recurrence for upper and lower tract is quite high for these patients. Also, about a third of the patients with low-risk disease will ultimately progress and require a nephroureterectomy. And so the progression rates are generally considered low, but some series have demonstrated up to a 20% rate of progression in stage, so it's not insignificant. And then one thing you'll notice about a lot of these larger series is they're relatively old. So I think there's a lot of room for improving our data in this space, especially because we have a lot more technology, like better technology, newer lasers, and that may actually improve a lot of our outcomes for this disease. And then another option that's less frequently encountered is performing antegrade ureteroscopy or performing percutaneous access for tumor resection. And for large tumors, you can actually get percutaneous access, dilate the tract, and then place a resectoscope in the kidney and resect the tumors, especially for large, bulky tumors. And obviously, this is in a case where you're really trying to preserve the kidney. The main issue with this technique, well, one issue is the concern for tumor seeding. So if you put a percutaneous tract, there's risk that you're spilling tumor into the retroperitoneum. So you really want to avoid this if you're doing it for high-risk disease. And then also using a cautery loop in the kidney is a little treacherous. So you have to be really careful that you don't perforate the calyceal system, and you can get into some heavy bleeding, and then also you can seed the retroperitoneum or the renal parenchyma itself. So I think it's a good option and technique to have in the toolbox, but it's pretty rare that you'll end up using this. And then in terms of which lasers to use, there's really no consensus on what the optimal laser is for upper tract disease. As I mentioned, I think there's substantial area for improvement in this area for upper tract endoscopic management. I think most of what's recommended and written about in regard to laser is just based on the fact that that was the laser available to the surgeon, and so that's what they used. There's very few direct head-to-head comparisons looking at different laser types for upper tract disease. I thought this was kind of an interesting study. They took ex vivo pig kidneys and looked at the laser properties of different laser types, and they compared the holmium and thulium laser. And obviously the kidneys didn't have tumors in them, but they looked at different properties, including incision depth and also the coagulation area of the different laser types. And they found that for the holmium laser, the depth of the incision was higher and the coagulation area was lower. And it was opposite for the thulium laser, so that had better coagulation area. And so if we think about what the ideal properties would be for a laser for upper tract disease, we want a laser that has not a minimal incision depth and then also a large coagulative area. And so theoretically, the thulium laser may be a better option for treating these tumors, but obviously requires more in vivo studies in humans and direct head-to-head comparisons. And so lastly, in the OR, when I'm doing the endoscopic management, I'll give a post-operative gemcitabine dose. And we extrapolate this data from the low-risk non-muscle invasive bladder cancer management. And I also will do this after radical nephroureterectomy. And overall, the hope is that you're reducing the risk of tumor seeding of cells that might be floating around in the bladder. And so we'll do this both for endoscopy and then also after radical nephew. And so it's generally recommended after your endoscopic management, when you think you've completely cleared the tumor, that you reevaluate these patients within 1 to 3 months after their initial management. And like I said, if it's a bulky tumor, it might take multiple weeks of going back to the OR before you get to where you think they're R0. And then once you think that, you have to come back in 3 months and see if there's any residual disease. And the reason for that is in some studies, it shows up to about 50% of patients still have residual viable tumor on biopsy. So doing that last look is very important to make sure that you've completely resected everything. So now moving on to adjuvant therapy for upper tract urothelial carcinoma. This is kind of advanced a fair bit in the last couple of years. And primarily, one of the biggest advances came with the development of this mitomycin reverse thermal gel, commercially known as gel mito. And so this is a gel that's solid at body temperature or relatively solid at body temperature and then liquid when you cool it down. And so the advantage of this is when you inject it into the kidney, when it warms up at body temperature, it'll sit in the kidney and slowly dissolve over a period of 4 to 6 hours. And the idea is that you're delivering the mitomycin over a longer period of time versus if you just inject it without this gel, it would just wash right out into the bladder and you don't get a lot of tissue contact time. And so in this trial, they evaluated its efficacy, and in the trial, it was given in a retrograde fashion using 5 to 7 French axis catheters. And so they had to take all these patients to the operating room to do that. And the volume instilled is generally determined by injecting contrast into the kidney and averaging the amount of contrast it takes to fill it up, and that tells you how much volume you should use. And the primary endpoint of this trial was looking at complete response rate, which is defined as a negative endoscopic examination and negative cytology at their primary disease evaluation after resecting the tumor completely. And so for the patients that had a complete or a partial response, they were then eligible for up to 11 monthly maintenance doses. And this was a single-arm phase 3 trial, and they enrolled 71 patients total, and 52% of those patients had a previous upper tract disease history, and then the remaining, this was their first diagnosis. And the patients had a median of 2 papillary tumors and a median total tumor burden of 17 millimeters, and how they assess that accurately is kind of a good question because it's not easy to figure out how big a tumor is on ureteroscopy. But regardless, 86% received all 6 induction treatments. And then the patients received a variety. Some did it under local anesthesia, some were under sedation, and then most of the patients had a 7 French axis catheter used to deliver it. They saw 59% of patients had a complete response at their primary disease evaluation visit, and then 41% did not have a complete response. And then the median follow-up for the patients who had a complete response was 11 months. And overall, looking at the adverse events, 94% of the patients had any level of adverse event. The most common serious adverse event was a ureteral stricture, with 44% having ureteral stenosis and 6 of them having a grade 3 ureteral stenosis. So obviously a concern was the rate of ureteral stricture for this using the mitomycin gel. They had published then a subsequent study that had longer follow-up to assess the durability of the mitomycin gel response. And overall, there seemed to be some durability in the response, but it wasn't as good as they initially reported. There was also very inconsistent use of maintenance therapy, but there did appear to be an association between receiving maintenance therapy and the likelihood of developing a ureteral stricture. And then on the longer follow-up study, they found that compared to their original study, there was less durability than they originally found. And so after 12 months in the 41 patients, the durability was only about 56%. So, you could argue, well, 56% is pretty good for a durable 12-month response, but then there's still almost 40% of patients who did recur within a year. So you have to balance that between the risk of ureteral stricture. So in summary, 59% had a complete response, and then among those patients, about 56% maintained a complete response at 12 months. And there's obviously concerns about the rate of ureteral stricture. There's also a lack of a comparator group in this trial, but it's hard to develop a comparator for this disease space. And then there's also continued question about the value and duration of maintenance therapy. But our practice at UW is to offer maintenance therapy and discuss with the patient whether or not they'd want to do it. And then also to overcome some of the issues with the mitomycin gel, here at UW, when we started this program, we came up with an Antegrade approach for delivering the mitomycin gel. And the Antegrade approach was theoretically to try and overcome One, the issue of the ureteral stricture, because I felt that by putting the access catheters up so frequently, it was irritating the ureter and potentially causing more issues with damage to the ureter leading to the stricture. And then also by doing an antegrade approach, it improves the clinical efficiency. The patients don't need to go to the operating room. And then also it can be delivered by a nurse in the clinic rather than the physician having to put an antegrade or a retrograde access catheter up for every single installation. And then lastly, I think the tolerance for the patient is better than having to get a scope and an access catheter with each dose. So we developed this antegrade protocol of delivering mitomycin gel. And so for our pathway, the patient's diagnosed and we determine if they're eligible. And then we put a stent in most of the time at the time of surgery, and we'll remove that within 1 week to try and reduce the risk of tumor seeding and get the stent out as quickly as possible. We'll consult IR and they'll place a nephrostomy tube. This can be a little bit challenging for IR because these patients don't have hydronephrotic kidneys like normal. So there was a little resistance at first, but then, I said, well, aren't you good enough to do it? And then they felt obligated to prove themselves. And then I haven't heard anything since then. And then once the tube is in, we let the tract mature for a minimum of a week. The concern is if you don't mature that tract, mitomycin gel can spill around the tube and get into the retroperitoneum. So you want to let that tract kind of close down. And then, for the first dose, I'll be there to get the measurements of the renal pelvis. So you inject some contrast and average over 3 injections how much contrast it takes to fill up the renal pelvis. Then you use that volume as the volume you'll instill for the mitomycin gel. And then the remaining induction doses after the first one will be given by the nursing staff. And then in 4 to 6 weeks after their last induction dose, I'll take the patient to the operating room for ureteroscopic evaluation. And if there's response, I will offer maintenance therapy to the patient and they'll get a dose every month, once a month for up to 11 months. And then in terms of monitoring, we'll check CBCs, and this is due to the possibility of aplastic anemia, which has been reported with the mitomycin gel. I haven't personally seen it, but it is a real risk, so we'll check CBCs. And then we also have patients take sodium bicarb prior to their doses to alkalize the urine. And then we check UAs to make sure that they don't have a urinary tract infection. And then for patient comfort, the nephrostomy tube is capped in between doses. We don't have the patients flush the tube, and that is to try and reduce the amount of bother for the patients. And then this is just kind of pictures of what it looks like when we deliver it. It's liquid at cold temperatures, but it's still pretty thick slurry, even at cold temperatures, and you really have to be careful not to warm it up. Even holding the bottle with your hand will start to solidify it. So it's on ice the whole time. And then there's this little delivery mechanism that increases the amount of torque you have to inject it, because if you just try and push it in with a syringe, it's too thick, you can't do it. So they have this whole device that you use to inject it. But in terms of tips and tricks for giving mitomycin gel, I think selection is obviously critical. We only use it for low-grade disease currently, and it's currently the only population it's approved for. There have been small studies looking at use in the high-grade population, but I still prefer, if we're going to use topical therapy, to use BCG, because the data is not really present for mitomycin gel at this point, but potentially in the future there will be data and potential trials looking at use in high-grade disease. The route of administration, in my opinion, should be antegrade, particularly for renal collecting system tumors. You could make an argument for retrograde delivery for ureteral tumors to better coat those tumors, but I think in terms of clinical efficiency and then the risk of ureteral stricture, we haven't had a single ureteral stricture since we've been giving it antegrade. So knock on wood, I think this approach is better. And then, there is a rationale. It was designed as being a chemoablative technique to actually reduce the tumor size itself. I personally think it works best if you reduce the tumor size ureteroscopically as best as you possibly can before you give the gel mito, because I think the tumor size is important for recurrence, and I think it works better at preventing recurrences once the tumor's been more fully ablated. And so just a few words about antegrade BCG therapy. I think there is a limited role for this therapy in upper tract patients. It's used primarily in imperative indications for renal sparing surgery when patients aren't candidates for nephroureterectomy or they want to avoid dialysis, but you have a high-grade tumor. This study evaluated patients with high-grade tumors who were either CIS or high-grade TA or T1, and they were treated with antegrade BCG weekly times 6 weeks to try and prevent recurrence after complete endoscopic evaluation. And so the authors found a pretty high recurrence rate, 47%. 17 progressed and 11% ultimately did require a nephroureterectomy. Of the patients that they looked at, they found that the CIS patients actually responded better and had better outcomes with less recurrence and progression compared to the high-grade TA or T1 disease counterparts. And so from this study, the authors concluded that CIS may actually be the best indication for antegrade BCG, and the TA or T1 disease are less likely to respond. Obviously, I think the main issue with BCG is the dwell time. You know, when you inject BCG, it essentially just washes right down into the lower urinary tract. So to overcome this, we have protocols developed where we instill the BCG very slowly over 1 to 2 hour period of time, basically dripping it in to try and improve the dwell time in the kidney. And then also we monitor the pressure at which we're giving the BCG, because if you inject it at a high pressure, it'll go into the bloodstream and then you'll get BCG sepsis. So it can be a little bit dangerous potentially. So overall, I think this is kind of a last-ditch effort to try and avoid nephroureterectomy, and you really need well-selected patients for using antegrade BCG. Lastly, these patients all need stringent follow-up. We talked about the very high recurrence rates for this disease, and this is a lethal cancer. So you need a strict follow-up protocol, and this is the recommended schedule by the AUA guidelines for low-risk non-extirpative management. And it includes both ureteroscopy in the first year, as well as upper tract imaging and continued surveillance of the lower urinary tract. And they recommend up to at least 5 years, and then after 5 years is shared decision-making. And then for high-risk tumors, patients who undergo non-extirpative management, besides recommending a more stringent follow-up with more frequent follow-up, the guidelines say at 5 years, you really should encourage patients to continue surveillance. They didn't make that statement for the shared decision-making for the low risk, but I agree. I think, you know, I always try and encourage these patients after 5 years to continue their surveillance because we just don't have a lot of data and the recurrence rate is so high, you would really hate to miss disease that you could potentially intervene on. So in summary, as we talked about, for non-extirpative management of upper tract disease, patient selection is critical. Kidney preservation can offer similar oncologic outcomes to radical nephroureterectomy, and that's important in this patient population who are often very old and comorbid, but it does require a pretty stringent follow-up. There are newer treatment modalities, and our therapies have increased the ability for renal preservation. And adjuvant therapies such as the mitomycin gel, the data is evolving in terms of the outcomes and complications, but there does appear to be some evidence of efficacy at reducing the risk of recurrence. And as I mentioned, this is an aggressive disease, even in the low-risk population, so stringent follow-up is critical for these patients to have good outcomes. So that's it. Thank you for the opportunity to present, and I'll answer any questions.
Any questions for Dr. Shapiro?
Yeah, great talk, Dan. I think that the follow-up that you show at the end and kind of the structure to it is important. I think that was always a challenge when I've seen more of these in the past. It's just, when do you stop doing your uroscopy? You know, do you really trust the sensitivity and specificity of your imaging? Interestingly, Ralph Klayman was here about 22 years ago as a professor. When any patient he had with upper tract urothelial carcinoma, he would incise their ureteral orifice, and he would do office ureteroscopy just to be able to fire up and just look up anytime, all the time. So that was interesting. You know,
yeah, when I was in fellow, we did office ureteroscopy to survey the upper tract. I think, yeah, it's not the most pleasant for patients, that's for sure. And it requires a lot of your clinic. So I think the AUA guidelines are a good happy medium there. I think early on you're doing more ureteroscopy, but then you're relying on the sensitivity of your imaging. So yeah, you kind of have to balance that. I think doing the in-office ureteroscopy can be a challenge.
Santiago.
Thanks. Nice talk, Dan. I had a question for you. In residency, I didn't really have a chance to do any surveillance cystoscopy on these gel-mito patients, but what you're doing in terms of antegrade installation is interesting. I was just kind of curious. I mean, like considering that people get like mitomycin-based cystitis, when you scope these people's ureters afterwards, in folks who perhaps do end up getting strictures, does that end up being more of like a pan-ureteral issue, or are they more focal? Just thinking like if there's any sort of direct effect from the mitomycin itself, or if it truly is more of an instrumentation kind of issue.
Yeah, I think it's probably a combination of both, but the strictures, I haven't personally had any patient with a stricture, knock on wood, but the strictures that I have seen in the literature, and then we had some in fellowship, tended to be more focal strictures, which is why I was thinking it may be more related to trauma. But that trauma is exacerbated by having traumatic injury and the mitomycin being on top of that injury. So it's probably a combination of both. In terms of when I scope these patients after getting the mitomycin gel, they actually look relatively normal. So I'm not seeing like a lot of, inflammatory reaction in the kidneys or in the bladder. So it looks pretty good.
Dee's pointed out there's a question on the chat here from Dr. Best. She says, great talk. Can you speak more to cytology? It sounds like there is a lot of onus put upon it for upper tract, which sort of contrasts with how we often view it for lower tract. I know there's a ton of institutional variability, so can you speak to in general as well as to our own institutions?
Yeah, I think our cytology here at UW is pretty good, actually. They'll detect tumors long before they're clinically visible on our cytologies. She's absolutely right in the fact that there is variability in how the cytology is read, and then also on how well your cellular concentration is to perform a cytology. So I think there's more emphasis placed on upper tract disease because it's often the issue is not so much that you're missing tumors, it's that your tumor that you're sampling, there's sampling discrepancy between what's actually present and what you detected on your biopsy. So you often are in a situation where your biopsy may show low-grade tumor, but the cytology actually shows that there's probably a high-grade component that you just weren't necessarily detecting on your biopsy, which, as we know, the biopsy samples for these upper tract tumors is a lot worse than what we're able to achieve doing a TURBT. So I think that's why there's a lot more emphasis placed on the cytology aspect of upper tract disease, because you're really trying to detect those patients that have high-grade tumors, because we know those patients do not well in terms of the recurrence rate and progression. So I've even had situations where the cytology alone is kind of pushing us towards nephroureterectomy. And you can see with basically every prognostic nomogram that's been published, if you have a high-grade cytology, it's associated with worse outcomes. So that's why there's a lot of emphasis placed on it for upper tract disease.
Can you talk a little bit about any role of active surveillance in the management of upper tract urothelial? I certainly do that for some patients with low-grade bladder cancer, where they're old and comorbid. You're trying to minimize the morbidity of repeated procedures and treatments.
Yeah.
Any role for that in the upper tract, Dan?
Not currently. So it depends on how you define active surveillance. I think for upper tract disease, we know it tends to be a fairly aggressive disease, so we don't tend to watch the tumors. Also, doing active surveillance, you either have to do imaging, so you're relying on your imaging to detect small changes in the tumor, or you're having to take these patients to the operating room frequently. So if you've got an old comorbid patient, you don't want to take them to the operating room frequently to do endoscopy. And then also you may, because we don't know, our biopsies aren't very accurate, you may be missing a higher grade tumor and not realize it. And then, so I think there's a role for maybe watchful waiting in a patient who's old and comorbid, where you're just trying to reduce morbidity and, suspecting that they'll ultimately pass away from their comorbidities. But in terms of surveying a known tumor in someone who potentially could get therapy, we would recommend just giving them therapy with either endoscopic management or nephroureterectomy.
Okay, thanks again, Dr. Shapiro. We'll take a few minutes, Dr. Pallone, and then we'll switch up to M&M.